Okay, thank you for the introduction. Good evening, everyone. So I'll be talking a little bit about latest cancer treatment in the 21st century, and this will be my outline. I'll be talking a little bit about screening with ctDNA, which is something new, and I'll combine about types of cancer treatment, including with precision medicine and also with some case studies. Okay, so I think most of you would have seen this in the past few days. Breast cancer, colon cancer, and lung cancer is the top 3 cancers in Malaysia. And in females, you have breast, colon, and also cervix. And in males, it's actually colon, lung, and also prostate. So when we talk about National Cancer Screening Program, it's always the top cancers which is available in the country. So these are the top 6 which is available. So in Malaysia, we also see that Chinese have more higher risk of having cancers compared to the Malays and Indians. And this has been proven in a few cancers, especially lung cancers, where we do find certain mutation, like the case previously Prof presented. I'm sure it's a Chinese patient because EGFR is quite common among Chinese females. Okay, and in Malaysia, we always detect cancers at a late stage. That's the unfortunate part. A lot of stage 3 and stage 4 cancers. So we need to do better. And why do we need to do better? Because a stage 1 cancer patient, if you're talking about 5 years survival rate, is about 75%. But when it goes to stage 4, you're talking about 17.3%. And these are patients which are treated in 2011, which high chance is actually mainly from chemotherapy, where down the line we have multiple new drugs like targeted therapy, immunotherapy, which would have increased the survival rate much more. Okay, so traditional screening is how you do is like you have a few different tests which I'll mention later. So you have a normal cell, and this is a long process where it turns into a cancer cell. This takes months to years. Okay, so when you talk about screening, you're talking when the cancer is already visible to the naked eye, either from the imaging and also from the surgeon's view. So breast cancer, you do mammogram and ultrasound, and colon cancer, you do FOBT and colonoscopy. And lung cancer, there's a van outside, you can do your chest x-ray with the AI screening, and any which is FDA approved is actually low-dose CT scan. And prostate cancer, you do a blood test called PSA, and also you can do a digital rectal examination. So every cancer has its own, and cervical cancer, you do your HPV swab or you do a pap smear. So every cancer actually has its own screening tool. You can't just do one test to detect cancer. Okay, and this is what which is latest in the 21st century, where we want to detect cancer before it turns to macroscopic, where without doing a scan, you can actually detect cancer by just doing a blood test. And this is what we call circulating tumor DNA. Okay, so what it means traditionally is where you actually have a cancer cells, and the cancer cells actually shed tumor cells, circulating tumor DNA, which you can detect from your blood cells. So you take a blood, this is not cancer markers, you just take a blood, you send to the lab. They can actually check and see whether you have circulating tumor DNA in your body. Okay, and depends which panel you choose. They can do like 5 different cancers, 20 different cancers, or 30 different cancers. Of course, with higher cancer detection, of course the cost will be more. A smaller panel will be much cheaper. So how cancer happens in a human body is, this is how you detect the cancer, and this line is when you detect by circulating tumor DNA. And this line is when you detect by imaging, like your mammogram, ultrasound, or your pap smear. So tumor cell starts, it grows. You will not detect it in any methods initially. We are trying to bring this detection rate lower down. So when it reaches a certain point, before it becomes macroscopic, you can detect it through your blood test. And then once when it's already grow and became macroscopic, then you start detecting on your imaging test. So this is how a process grows. So circulating tumor DNA is detected at this level. Okay, and as mentioned, depends what panel you choose. Some panels will give you like the top 5 cancers in Malaysia. Some panels give you a lot more. And your sensitivity and specificity rate is about 73 and 85%. It takes roughly about 2 weeks to get the report done. Okay, so this is not prime time yet. Okay, it is still not in the guidelines. It is still, there's a lot of clinical research being done, but there's a lot of people who are already using it. But it comes at a caveat. You can't rely truly on just doing circulating tumor DNA. You should still go for your traditional screening until you have more concrete data where FDA actually says, okay, you can stop doing all your normal screening and just do blood tests. Then we can go ahead with it. But as of now, you have to do it with your normal screening test. Now, what a lot of Malaysian population do is by just doing tumor marker. Tumor marker is not a standard screening test for any cancer. Okay, it has lacks specificity and lacks sensitivity also. And it can be falsely raised in benign cancers, like a smoker will always have a high CAA, any inflammation in your body will always have a raised CA 99. Okay, and some cancer, even though you're stage 4, it can still have a normal tumor markers. Okay, only PSA, which is FDA approved, can be used as a screening tool. So you can do your blood test for PSA to detect cancer, but any other cancer, you still have to go and do the traditional screening method. So we hope that circulating tumor DNA will be prime time, but I think it will take a few more years to be prime time. Okay, so next new diagnostic tool what we have, okay. Traditionally, it's always like ultrasound, X-ray, and then you do a CT scan or MRI. Now we have PET scan, and we have different version of PET scan. We have FDG PET, we got FAPI PET, we have gallium PET. So different cancers will have different PET scan to go through to detect the sensitivity of the cancer, where it has spread. Even small lesions you can actually see from your PET scan. And lab test, which is traditionally done before anyone goes for surgery or any treatment. And of course, you need a biopsy. Now, a biopsy is very, very important for a cancer patient because it tells you your disease and it tells you how your biology of your disease. So some treatment, most treatment is always dependent on your biopsy. It tells you your cell type and it tells you all your mutation. Now, mostly we always do a tissue biopsy, but nowadays you can do something what we call a blood biopsy. Same concept like circulating tumor DNA, where you take your blood, you send to the lab, and you can actually see a cancer patient's what mutation is present inside the body. So from what mutation is present, you can actually find certain targetable drugs and use those drugs. So another function of circulating tumor DNA is for disease monitoring. So traditionally, for example, say you have a colon cancer, you go and do a surgical resection. Subsequently, say you're stage 1, stage 2, there's nothing much, you don't need any treatment. If you're stage 3, you need treatment. Stage 2, certain different biology or bad biology, you might need some oral treatment. So those are traditional ways. But now moving forward, you can do something what we call circulating tumor DNA, where we call it minimal residual disease, where you take your blood test. You can actually see whether there's microscopic blood tests in your body. So there's a lot of trials which have proven if your MRD post-surgery is negative, you live longer. If it is positive, your survival is shorter. But as of now, we do not have any concrete evidence for example, like someone stage 1 who has a positive circulating tumor DNA, positive MRD to do chemotherapy. We do not have that evidence yet. But we do have evidence to do MRD as one of the screening tools, which is FDA approved and NCCM approved. So what's the concept why we do circulating tumor DNA in early stage cancer is the moment you have a macroscopic disease, okay, cancer cells do have stem cells also. So when you remove it, sometimes some stem cells will left behind and that stem cells will actually grow and turn into a recurrence. So your circulating tumor DNA will detect all these microscopic cells and tell you whether it is positive or negative. So back to the same graph just now. So once you detect a cancer, for example, say a surgeon does a surgery, so your cancer cells will drop in your body. If you're lucky enough, it just drops, remain here, you don't have cancer recurrence at all. But if you have a cancer recurrence, small level will not be detected by any test, but the moment it starts growing, you can detect it through your circulating tumor DNA, which is your blood test, and then subsequently when it grows big, it becomes macroscopic. Okay, so this top layer has already been established by doing CT scan, PET scan, ultrasound, X-ray. But this intermediate layer is we are moving forward to do it. Okay, with circulating tumor DNA. Okay, so now next I move to types of cancer treatments with some case study. So the pillar of cancer treatment has always been surgery, chemotherapy, radiotherapy, targeted therapy, and immunotherapy. So this has been there for many, many years, and throughout the years, every pillar of it has its latest advancement, from surgery all the way to immunotherapy. So before we decide a patient for any treatment, there's always something what we call a multidisciplinary team meeting. So no one doctor can actually treat a cancer patient. You definitely need a team to get a better success rate for a cancer patient, where it consists of surgeons, physicians, radiologists, psychologists, the nurses and all will come together, discuss the case, and actually come up with the best plan for the patient. So every week, normally most of the cancer centers will actually have a weekly multidisciplinary team meeting. Okay, so for surgery, those days people do open surgery, then we move into laparoscopic, minimally invasive, then we move to robotic surgery. Hopefully later, surgery with full AI, maybe a computer will be doing surgery later on, nobody knows. But this has been going on, so I think moving forward, definitely surgery, always you have better methods to do it to reduce your blood loss and faster recovery. So for me, I'm a radiation oncologist. So in radiotherapy also, as time passed by, we started with 2D. When I entered into masters, we were doing 3D. Then when I graduated, we were already doing SBRT. And particle therapy is something like proton therapy, where Datuk Lee went for treatment for his nose cancer. So in a nutshell, your tumor is the same size, but your normal tissue being radiated keeps on getting smaller with a better treatment. So with 3D, you get a lot of normal tissue radiated. But with IMRT, SBRT, very little normal tissue get radiated. Okay, so if you're talking about 2D, this is how a tumor will get. Your normal tissue all will actually get radiated throughout. 3D, it becomes more conform. IMRT, even all the small curvature of the tumor, you can radiate nicely without damaging the normal tissue surrounding it. So this is an example of a lung cancer patient. She's quite an elderly patient. She's about 78 years old. So she was found to have a solitary lesion. We did a PET scan to make sure there's no cancer anywhere else, and we found there's only one lesion in the lung. So part of the treatment, normally for lung cancer, best is always surgery, but because she has a lot of comorbids, the next best thing, we offered her stereotactic body radiotherapy. So what we do is, we track the tumor, we do a 4D scan, because our radiation is fixed, but your tumor tends to move. So you need to do a breathing pattern to see how the tumor moves during the radiotherapy session, and then you do a radiotherapy plan. So for a SBRT plan, the center part is where you get the highest dose. This is the smaller dose surrounding it. You don't get any dose surrounding the other structures. But if you do a normal IMRT or a 3D plan, you have a lot of splash dose all around. Okay, so this is a SBRT, this is a 3D plan. Yeah. So this is the splashing dose, but you don't see any splash dose around here. So the area get radiated will be there, and your normal tissue, only minimal get radiated. But here, there's a lot of tissue being radiated. So toxicity will be reduced. As time passed by, your tumor, every 3 months, we did a scan, subsequently reduced and it became fibrosis. So some people might think that this is cancer recurrence. We did a PET, it was actually clear. Okay, and now she's already 4 years down the line without any symptoms. So we are using the same technology as SBRT for prostate cancer. And nowadays for prostate cancer, if you do not want to do surgery, you can straightaway go for SBRT. It is clinically proven to be similar efficacy and less toxicity. So this is the center part is a prostate, where we want to radiate. This is one technique, what we call IMRT. This is VMAT, where there's a lot of splash dose all around the tissue. But with SBRT, it is much lesser. This is small seeds, what we call brachytherapy. We don't have it in Malaysia. Institute Cancer Negara used to do it, but I heard lastly they don't do anymore. So brachytherapy is for very early stage prostate cancer. So this is gold fiducials. It's actually real gold, which we insert into the prostate for our SBRT treatment delivery. So if you want a much more tighter margin so that you do not get a lot of radiotherapy dose being splashed around, you can actually put a gold seed inside there, and you can get a much more tighter area being radiated. So your normal tissue will actually be spared much more. So with new technology, people always think comes at a price, but actually no, it is less fraction, so it is much cheaper compared to the normal radiotherapy. Similar toxicities and more conform to the target. So anything in the brain, we call it stereotactic radiosurgery, where we have gamma knife, where we use gamma rays. So normal radiotherapy, we use electricity, we use normal X-rays. So this is gamma rays, there's a radioactive source of gamma inside there. So a patient lie down, there's a cone around there, there's 192 holes from it, and small finite beams will come out to actually target to just one location. So this is a case where a patient actually had multiple brain lesions. I think roughly there was about 20 lesions in the brain, and it was not operable because it's 20 lesions. Doesn't make sense to operate for that such many lesions. So we did gamma knife, and this is her scans after 3 months where you do not see any lesions anymore in the brain. Okay, because it is small, it's easier to disappear. But some lesions, which is big, is a little bit long. It takes longer time, and sometimes it doesn't disappear. So this is a kidney cancer patient where you have a lesion in the brain there. After 5 years, you don't see anything there already. Okay, so similarly, this is a colorectal cancer patient. Gradually, over 6 months, 9 months, 12 months, and 5 years, you can actually see the tumor shrinking. And finally, you don't see anything much. Of course, I show you a good scan lah. There are patients who actually progress also, but these are the one which is success stories lah. Okay. So moving forward, we also have something called targeted therapy. I think Dr. Jennifer will be talking more about novel treatments later on. But the gist of it is, when you have a cancer patient, why biopsy is very important, because a single tumor biopsy, you can actually find all these mutations inside. Okay, and this is for lung cancer. So when we do a tumor biopsy, we see number one, cell type, adenoCA or squamous cell. Then those days we give chemo, but nowadays we do a lot of molecular analysis. And how we do molecular analysis is actually by doing something called next generation sequencing, where you take your tissue or your blood, okay, we can do blood NGS right now, We do a lot of preparation, then we do the sequencing, which takes roughly about 7 to 10 days, and you come out with a final report what mutation a patient has and what targeted therapy can be used to target those mutations. So you know it will work better than chemotherapy. So over the years, you have seen so many different mutations coming up. And we barely scratch the surface. There are even more mutation which is already there, but we do not have a targetable drug for it at the moment. But moving forward, I'm sure there will be more research being done, and cancer is always something which always every 6 months something new will come out. So back in 2008, this was how we treated a lung cancer patient. We just give chemotherapy or bevacizumab. But now in the 2024, you have to do all these different mutations. And each mutation has roughly about 2 or 3 drugs to target. So we have a lot of drugs nowadays for our cancer patients. It's just finding the right drugs for the patient. So previously in 2009, if you're talking 5-year survival rate, at that time probably you only have 1 or 2 targeted therapy. You're looking about 15%. But in 2019, 5-year survival rate for a lung cancer patient has shot up to 53% because we have a lot of targeted therapy drugs available. And now in 2024, definitely is much higher. And this is actually one of the bombastic trial which actually came out where tumor all disappeared in a cancer patient. It caused quite a hype, but it was only 12 patients inside this trial where rectal cancer, they did some treatment and all the tumor disappeared. So this is something what they did with immunotherapy. So those patients had a specific mutation called MSI. MSI was high in them, and they actually used immunotherapy which has very good response for MSI high patients. So the tumor all actually responded very well with immunotherapy. So what the difference between targeted therapy and immunotherapy? Targeted therapy has effects on your healthy cell and cancerous cell also, but immunotherapy in a nutshell, it just boosts your immune system to fight against cancer. So it uses your own immune cells, something like what Prof. Chin was saying just now. So this is an example of a breast cancer patient. She's triple negative breast cancer. With, this is a breast lesion and also a lot of liver lesions. After immunotherapy with pembrolizumab, you can see there's nothing there. Even in the liver, everything is clear. Okay. So with immunotherapy, you can actually have complete response, but these are complete response on imaging. It doesn't mean that your cancer has disappeared from your body. You will still have always microscopic cells in them. So one way what you can do to monitor before the cancer becomes macroscopic is back again you can do your minimal residual disease with circulating tumor DNA. So this is a lung cancer patient. So after immunotherapy, you can just see some scarring around it. Okay. And this is a patient with melanoma. Started off in the axilla with multiple lesions all over. With EP-Nivo, after I think 6 cycles, you don't see much lesions anywhere else. Very minimal lesions still present. So you do get a lot of response with immunotherapy, and immunotherapy is something I wouldn't say quite new. It's about 5 years down the line, but there's a lot of newer immunotherapy drugs coming out. But with all of this treatment, it comes at a cost. Cost definitely will balloon up. Okay. So this is something what I did for one of my previous presentation, where this is how much it costs to treat a cancer patient right now. Okay, so if you're talking like a scan and then you go for a biopsy, if you go for some treatment, you're talking like immunotherapy about 300,000, and this is only 1 year's cost. If you're talking targeted therapy, probably it's 92,000 or 165,000, depending which drugs you use. So cancer treatment is not getting any cheaper, it's getting more and more. Okay, with newer technologies always come at a price. Certainly, especially SBRT will be cheaper lah, but drugs always is more expensive. Oops, sorry. Yep. So as a summary, get a good coverage and always early detection save life. Please go for your cancer screening. There's a lot of cancer screening being done down there. And I just did my chest x-ray with AI. Thank God I'm cleared for lung cancer. And eat healthily and also exercise regularly. And see your doctor if you have any symptoms. Thank you.
Thank you, Dr. Malwinder. We open for Q&A. Yes, Doctor.
Dr. Malwinder, I am Vetri from Monash.
Hi.
No, you have done well presentations, very clear. As you mentioned, gamma therapy. Mm-hmm. So we can apply for at any stage or only the first stage or second stage of brain tumor or anything?
Okay, so gamma knife, particularly gamma knife, is only used for brain tumors. Okay, so either you have primary brain tumors or you have metastatic lesion, which is primary from somewhere else, which has spread to the brain. And gamma knife is used for cancer and also non-cancer. Okay. So for a tumor which is big, you can't use gamma knife. Okay, gamma knife only works for a smaller tumor. And if you have a tumor causing symptoms like obstructive symptoms, or it's like patients having neurological deficit and all, then that one definitely have to remove by surgery first. Okay, because radiotherapy takes time for it to shrink also. It doesn't shrink immediately. Okay. So anything with compressive symptoms too big, you have to go for surgery first. If you're talking cancer which gone up, that one high chance, I wouldn't say high chance, about 90% of the time you can always just use gamma knife. But 10% you still have to remove to reduce the symptoms. Okay. If you're talking benign cancers like schwannoma, meningioma, if it's still small, you can use gamma knife. But if it is big, you still have to remove by surgery.
Okay. Thank you.
Sure.
Thank you for your questions, sir. Any other questions from the floor? Yes, Dr. Hadi.
So I really enjoyed the discussion of the screening error detection and picturing with the impact on the staging. This is something we always need to think back on, and the advancement of radiotherapy. And even now the particle proton therapy, except it's a very expensive toy to get. It's a tool, equipment, technology. What's fascinating the most is the cost. This is, by the way, all this cost is just treatment. We're not taking into consideration the time off, the transportation, the caregiver time, all of this. And so on top of all of that, you add the same social cost, the cost of living, the transportation. So this is so that's why the investment in error detection, no matter, people look sometimes on the circular DNA or liquid biopsy, it's very expensive. So now it's, as you mentioned, it's not still in the trial, it's not the mainstream treatment survey screening. But some people get it, got done and send out test at Qatar, and it's the panel is around $2,000, and now we are working on to getting it, looking at feasibility of using it, but as an adjunct, as a way, because really, if we look, no matter what cost we put up front for error detection, no matter how much cost we put there, it is more cost effective looking at the end of the line. Yeah. And and I may ask you later for that slide, because the cost in Malaysia, almost kind of similar to the cost in Qatar to a certain degree. So it's very, very fascinating. I like your effort in that. Thank you so much.
Thanks.
Thank you, Dr. Hadi. Any other questions? Okay, we'll close the Q&A. Thank you, Dr. Malwinder.
It's one question.
Hi, Doctor. Thank you. As we have hyperthermia booth in this congress. So as hyperthermia is a radio sensitizer, does Pantai or you yourself plans to implement this combination with radiotherapy or maybe immunotherapy in the future?
Okay, so I was first introduced to hypothermia when I was doing my training in University Malaya. So we did see some benefit, but those days hypothermia back in 2010, those machines was like very simple one. Okay, with every technology you have better hardware. So certain hypothermia hardware, I haven't seen the one here, so I wouldn't comment much. But certain hardware is, you don't get much benefit, but they are like very high-end hardware where you can actually get from certain company, which actually has been proven to have a lot of clinical evidence when you combine radiotherapy or immunotherapy or even chemo with hypothermia. Okay, so definitely there is a role, but it comes at a cost also. So in Malaysia, I don't think so there's any commercialized hypothermia machine. Mostly are still on clinical trials basis. I think UM is doing a hypothermia machine trial at the moment. And what I know, some centers are doing with just the basic hypothermia, superficial hypothermia, not the deep hypothermia. I myself, I believe the evidence will be more for deep hypothermia compared to superficial hypothermia.
So we conclude the Q&A. Okay, thank you, Dr. Malwinder.
Thank you.